Hello all, I am Dr. Tej Prakash Sinha, and in this topic we are going to learn about triage. Triage is very important, and in this talk we are going to discuss about the a bit background definitions, what are the goals, what are different types of triage, what principles we follow while doing a pre-hospital triage, the various categories or criterias by which we can say that this trauma patient or non-trauma patient belongs to this triage category, and a very brief about triage which is being used during disasters. So, triage is actually derived from the word trier. Triage means to sort out, to choose. So, triage is a system that prioritizes patients' treatment based on their urgency of need of care. So, actually this was started way back during the wars, where they used to categorize the people or the soldiers who can fight or who cannot fight, who is going to be saved by giving the medical care and who is going to die. So, from that it has been percolated to disasters and then to the civilian medical care. So, whenever you do triage, the idea is that the patient, which is a right patient, should get the right treatment at right place by right people in right time. So, these are the goals of triage whenever you do. See, there are various triage which we utilize. There are various triage system which has been described for the emergency room or the hospital based triage, like the AIIMS triage protocol, our own triage protocol which we published, and then other international triage protocols like Australian triage protocol, Manchester triage protocol. The very important is the emergency severity index protocol, the Canadian system of triage. But once you go in disaster, there are various different simplified way of doing the triage, that is a start triage and SALT triage. Start means simple triage and rapid transport of the patients. But let's come to our own domain of pre-hospital care. So, there is a triage protocol which we use in pre-hospital care. We call it as medical emergency triage and treatment systems. But here today we are going to learn about AIIMS triage protocol which is being utilized at hospital, and the same is going to work for our pre-hospital care also. So, let us see it about the AIIMS triage protocol. This is the AIIMS triage protocol which was being published in 2020, and after that many development has happened in our country. So, let us see why it should be utilized in the ambulance services or the pre-hospital care. See, once you receive a call, you reach the site and you are the first frontline health personnels. So, actually you are working the first eyes or the ears for the patients. So, at the point of incident or the scene, you have to take decision that whether this patient is so sick or not that sick. So, that clinical decision is as important as it is commonly being taken by the doctors inside the hospital. So, pre-hospital triage is pretty important. So, while doing this triage at the scene by the paramedics, that you can think about starting the care immediately to those who can die if we don't start the care, or they will have very bad outcomes if we don't start the care immediately, or you may still think that this patient can wait, especially when you have more than one patient, or even one patient is important to communicate that this is sick, this is not so sick. That is why triage is very important in pre-hospital care setting also. So, let us see what are the different triage categories. So, in AIIMS triage protocol, what we hypothesize that if we can go ahead with the traffic light system, so common public can also understand the triage. So, we chosen red, yellow and green. So, these are the common three triage categories which we use more often, and sometime you may receive a dead patient whom we label as black. So, these are the four triage categories: red, yellow, green and black. So, let us see what this red means. Red is those kind of patients who cannot wait for care. So, they require immediate care or what we call as resuscitation. If you will not give, they will either lose their life, limb or organ. Another category is the yellow category, where you do not have that kind of limb, life or organ threatening condition, but these patients have something for which you require either keep under you, observe, or investigate, or you may require to investigate and observe or reinvestigate, something like that. So they are stable, but they require some kind of care. Green are those patients who don't need that kind of observation or investigation. They are very simple cases, like just something is scratched, simple fever is there, or some minor illnesses are there. So you don't require any hospitalization, observation or investigation, just minor elements, get treated and get discharged from the hospital. So these are the red, yellow and green. So let's see what are the general principles of categorizing during doing the triage. So largely we divide in two segments, like trauma and non-trauma. So first and foremost, any patient, be it trauma or non-trauma, we look for physiology. So ABCDE, airway, breathing, circulation and disability. So physiology. And in trauma, we examine the patient and look for any injury, whether he is having amputation of limb, gunshot injuries, or what injury you are getting. So based on that, we categorize in different categories, red, yellow, green. Then comes the mechanism, like you don't have, physiology is normal, he is coming normally, he is not having external injury, but suppose somebody has fallen from third floor. So mechanism says that he might have something wrong. So let's examine, observe, examine, investigate, something like that. So mechanism. Sometime some specific population requires different kind of care or approach in a different way, like old age patients, the kids, pregnant women, patients with abuses like sexual abuse, child abuse patients. So they require a special consideration. That's why we have kept vulnerable population also while considering the triage category. Usually, if you have a vulnerable population, we try to give higher category. We don't give green, we give higher categories. Similarly, if you see in non-trauma, physiology is same. Here you were identifying the injuries by examination. So here you will examine the patient as per the complaints. In trauma you had the mechanism, but here we ask about the history. Like a diabetic patient is coming with fever and vomiting, you can think of diabetic ketoacidosis. So brief history. And again it is same for vulnerable population. Now whenever you triage some patient, when they reach your hospital or you are at the scene and you are triaging the patients, so while they are in hospital, they need to be treated at specific areas. So that's why you see here, if some red patient is there, if they reach the hospital, they have to be shifted in red area and treated at red area. So while you will reach the hospital, give handover, so these patients will be taken to red patient to red area, yellow patient to yellow area, green patient to green areas, because these areas are equipped and prepared to cater in that way what these patient or these category patients require. Let's see how practically we are going to do the triage at site. So once you reached with the ambulance at the site, so scene safety is very, very important, and how you will observe and know whether this patient is that sick, yes or no. So first and foremost, you can actually just by look you can say whether the patient is walking, non-walking. Obviously those who will not walk, likely they will have some serious injury, possibly, not always, but possibly. Sometime you may have patients with obvious injuries, like somebody has a stabbed in chest, a knife is just, you are seeing the knife is there. Somebody has the impalement injury, like a rod has gone inside the body and you are seeing the patient is stuck. Especially in road traffic trauma, many times somebody is caught inside the car and something has impaled. So just by look you can say that this patient is sick. Now after that what we do, we just examine, ask, क्या हो गया आपको, क्या नाम है आपका? So whether the patient is responsive or not responsive is again we can think of that whether the patient is fine or not that fine. So again non-responsive, likely they will be red, serious. Another way is just by a 10-second assessment. So this we can just ask the name, क्या है आपका नाम? So suppose somebody is saying that my name is Tej Prakash, that means he has heard your voice, he is speaking, so that means the respiratory reserve is good, airway is clear, that's why he is able to make voice, and you ask the name and he responded as name only. That means that his brain is also functioning. So just by 10 seconds you can understand his ABCD is fine. So those who are having ABCD fine in 10 seconds, you can say at least by now he is not a red. Later on you will examine further and thinking about what kind of triage category will give. And once you have done that 10-second quick assessment, then go for formal triage way, like checking the vital signs. So, may not be possible at the scene to check vital sign always, or if you have a patient who is obviously sick, take that patient as a red category inside the ambulance and re-examine and decide the triage further. So, that is the way while we reach with ambulance and approach the patient to get the categorization of the patient. So, now let us take some detail about the ABCD or vitals, that how we can say this patient is sick or red category or non-red category. Like if airway is compromised or threatened, we take it as red. So, when we say that airway is compromised, like unconscious patient, patient is severe shock, like blood pressure is very low, you have seen lot of bleeding is there, patients with maxillofacial trauma. So, these patients you can consider as their airway is compromised and they will be triaged as red category. Those patients like having burns, having hoarseness of voice, or they ate something and had reactions, hypersensitivity reaction, so they also have voice changes. So, hoarseness of voice, stridor, noisy breathing, or something in mouth like vomitus or blood is inside the mouth, and whenever they used to breathe they produce a gurgling sound. So, these are the telltale sign that airway is having problem and you will triage the patient as red. Saturation is again marker for both A and B. So, if the saturation is less than 95 in trauma, or in a patient of COPD or asthma, if the saturation is less than 90, we consider as red. So, I have listed red categories. So, all these features, any one of these feature is available, you will categorize as red. So, you can see some picture just by look you can see. So, tongue is swollen in the first picture, you can see a kid is having a foreign body stuck inside. So, one person you can see lot of burns, one person is having a stab injury or some injuries, which is having neck is having a problem. So, neck hematoma is again going to be a problem. So, these are some pictures which tells the airway is either compromised or threatened. So, you have to triage as red. Let us see what are the different criteria while assessing the breathing part. So, in breathing we check for respiratory rate, we check for saturation. I told that even in airway you will have saturation losses, but in breathing also we consider saturation. So, respiratory rate normally is 12 to 20. So, if you have respiratory rate more than 24 or less than 10, it is a problem, it is a red condition. Again saturation is same which we discussed. Sometimes those patients who are having respiratory difficulty or distress, they use their accessory muscles, like in the first picture you can see the sternocleidomastoid muscles and all the muscles are in use. So, you can see these kind of patients also. So, use of accessory muscle is also says severe respiratory distress. So, that means red condition. In circulation, we check the pulse or the heart rate, the blood pressure and capillary refill time. So, on field when you are on scene, may be possible to check the BP, may not be that much possible, but at least you can quickly check the pulse and quickly do the capillary refill. So, normally the capillary refill is less than 2 seconds. So, you just press here and leave that and check for the time and press, leave and say capillary refill. So, saying capillary refill takes 2 seconds. So, if it is delayed taking more than 2 seconds, that suggests the patient is in shock. Other parameter is pulse. So, if you have the pulse is very high, like you are having 130, 140 pulses, that suggests the patient might have shock or might have some problem. So, that requires reevaluation, but largely we categorize them as red. When you reach on the site, even if you are unable to use BP apparatus, just by putting your fingers over the radial pulse, if the pulse is absent or very feeble, you can think that he is in shock, maybe hypovolemia or something like that. So, you will triage the patient as red. In disability, we use different scales or scores. GCS or Glasgow Coma score or scale is one, but this is a simplified one and very useful to be used in field on scene or in route care, you can use very easily. So AVPU scoring system. So A means patient is alert, V means whenever you ask the patient, they will answer. So responding to verbal stimuli. P is they will not respond to verbal stimuli, you have to give some painful stimuli, then they will respond. And U is even after painful stimuli, they are not responding. So obviously those who are having response on pain or unresponsive, you have to label them as red. Okay. Those who are alert can be green, can be yellow, depending upon other parameters. See, this is the triage protocol which we have prepared from AIIMS, and this has been taken by Ministry of Health to be used in various hospitals, and we found that even the triage protocol inside the ambulance and in the hospital should be same. We should speak in same language. So we are going to utilize the same triage tool or the criterias. So you can keep one triage criteria form with you so that you can just check from there. So if you see on left side of the screen, there is a term what we call as fast track. So in fast track, even the patient is red, like you have one patient red, another patient red category came. So whom you are going to give priority? So those patients whose treatment is time bound. Suppose a heart attack patient or the myocardial infarction patient comes, so you require to do ECG within 10 minutes, better to thrombolize as early as possible, PCI need to be done within 120 minutes. So it is a time bound. Trauma, you have 1 hour concept or golden hour concept. So from trauma till definitive care, you must do within 1 hour. So time concept is there. So once you have the time concept like chest pain, likely myocardial infarction, stroke patient, unresponsive patient, those patients who are in cardiac arrest, these are the patients. Even you have 2 patients and any patient out of this are there, so you will give the priority to time sensitive conditions. So we call them as fast track. Even inside the red, you have to fast track these patients, so to save the life by doing timely management. And this criteria again, it is same. One side it is the physiology ABCD, which is quite common for trauma and non-trauma, and then you have various triage categories or criterias, like in trauma, injuries, mechanism, and in this side the history, examination, symptoms, those kind of things. So this is the triage form which we use, and these are the criterias. Let's see few case scenarios. Like a patient, young male, is screaming and saying, "Please help me, my leg is killing." So see, he is speaking, he is conscious, he knows about his problem, that means he is not going to be red. Since likely he might be having any fracture, something, so we have to do certain investigation and observe, so we are going to put them as yellow, not red. A young female patient having cyanosis, tachypnea and is breathing noisily. Again, you just think about what we learnt in A and B. So cyanosis is late sign, so she might die. So this is a red condition. An old male is lying in a pool of blood with his left pant leg is soaked in blood. So he must be having big injury, lot of blood loss is there, pool of blood is there. So we'll consider them as red. Another case scenario is 57-year-old male driver, and he is complaining that he is having episode of diaphoresis, chest pain, which is centrally placed and radiating to the left arm, crushing in nature. So this suggests chest pain is a bad chest pain, likely cardiac origin, maybe ST elevation MI, myocardial infarction. So this is going to be red, and inside red you have to do a fast track. So this is patient D. Patient D is 55-year-old female, sudden onset of voice change, weakness in arm. So how we diagnose a stroke? You must have learnt that facial deviation, then voice change, arm weakness, so fast. Okay. So facial deviation is F, A is arm weakness, then S is slurring of speech or speech disturbances. This is the time to see a doctor T. So this is a case of stroke. So you have to fast track this patient. Triage category will be red, but you have to fast track this patient. Okay, so this was about the day-to-day triage we are going to use while we are going in side the ambulances reaching the scene, at the scene and en route. Both we are going to use our Triage tool so that we can communicate to our command center and even to the other hospital where we will take the patient that I am bringing a red patient, I am bringing an yellow patient. Right now we think this patient is red, something like that. So, you have to communicate in Triage category also. Now, let us think when some disaster happens, how we are going to behave and how we are going to utilize the Triage during disasters. Let us learn something about disaster. So, disaster is an occurrence which is disrupting the normal conditions of existence and causing a level of suffering that exceeds the capacity of adjustment of affected community. So, what here important words are, the demand exceeds the capacity. Okay. So, need is much more than whatever you are having. So, resources are overwhelmed. So, you see a scenario day to day, you are having R resource and P are the patients. So, your resource is sufficient for the patients. So, this is normal. So, if you have some more patients with same resource, you can still stretch and do best for all patients. So, it's still manageable. So, we call this as multiple casualties, multiple, not the disasters or mass. Okay. But if your resources are overwhelmed with the patients, lot of patients are there and resources limited, in this scenario we say this is a disaster scenario or mass casualty scenario. And here idea is do greatest good for greatest number, not for best for each, okay, which we do in day to day. So, what kind of triage we use in during disaster? So, we call it as start triage. And it is very simple. You have to look. So, all walking patient will be considered as minor patients. Those who are non-walking, so walking versus non-walking, those who are non-walking, we just check whether he is breathing yes or no. If he is breathing, then you have to check the respiratory rate. If it is more than 30, so you have to triage as red or immediate care is required. If it is under 30, you have to check whether the circulation part of the perfusion is fine, yes or no. So, you will check the capillary refill. If it is more than 2 seconds, you have to think about that it is again red. If it is under 2 seconds, that means the breathing is fine, circulation is fine. Now, this is the time to check the mental status. So, you ask the name and check, either you can use the AVPU kind of thing. So, if he is unable to follow the command, simple commands, so that means it is red. On other side, if respiration is not there, so you have to think whether he is dead or not. Like suppose somebody is having some neck is tilted or having something, you did something and he started breathing, that means he is red. Still by doing some basic things like head tilt, chin lift, airway opening maneuvers, he is still not breathing, then you take it as deceased. So, you just remember one uh, term 30:2 I can do. So, those who are having respiration less than respiratory rate less than 30, walking, walking versus non-walking. In non-walking, respiratory rate less than 30, capillary fill less than 2, they are fine. Okay. So, just remember 30:2 is a very simplified way. So, this is start triage, standard treatment and rapid transport. So, this is the simplified way of reflecting start triage. Okay. Start triage simple way, just the same algorithm has been captured and reflected here. To summarize or the take home message, triage is very important, by which we can sort out the patient so that they can get the treatment based on the urgency of care required. Triage is performed in emergency departments or the hospital triage, or maybe at the field or the disaster scenarios, and at the pre-hospital level in day-to-day practice even. See, the goal of triage is to place the right patient in right place so that he can be treated by right persons in right time. See, red, yellow, green and black are the triage categories which we discussed in detail, and remember that simple triage and rapid transport, that is the start triage, is very useful during disasters or mass casualty scenarios. These are my references. Thank you.